This is Brian Campbell. I'm a physician here at McCady Hospital, where I'm part of the residency faculty. Along with me, there is present Dr. Kurt Rifleman. Kurt is a family physician as well and practices down at Midtown Clinic. And we have with us today Jeanlee Carver, a longtime friend of mine and nurse practitioner. I'm going to read her lengthy introduction here because it's very important for us to understand her background because it will have a tremendous impact on the rest of our interview. Nurse practitioner Jeanlee Carver developed and implemented the Children's Justice Center medical programs in Weber, Davis, Cache, Washington, Uintah, Duchesne, and Iron counties. She currently works as a sexual assault nurse examiner in Weber, Morgan, Davis, and Box Elder counties, where her exams include an assessment and treatment of victims of sexual assault, male and female, which includes significant history of the event, a general exam, injury identification, which includes photo documentation, evidence collection, packaging, administration of medications, and counseling for HIV and possible sexual infections. She retired in 2019 after 22 years experience in child abuse and neglect from the Weber Morgan Children's Justice Center for Primary Children's Hospital, Center for Safe and Healthy Families. Jeanlee is double board certified in pediatric primary care and adult primary care and is a sexual assault nurse examiner certified in both pediatric and adult assessment. She currently serves as past president of the Utah chapter of the International Association of Forensic Nurses and sits on many state coalitions, committees, foundations, and councils serving victims of domestic violence and sexual assault. A former critical care and emergency department registered nurse, she also practiced as a hospital supervisor in her nursing career at McCady Hospital in Ogden, Utah. Using her skills and knowledge, Jeanlee has added to her list of current employment working as a legal nurse consultant for prosecuting and defense attorneys within the Intermountain area and for the Federal Public Defender's Office. Jeanlee educated nursing and paramedic students at Weber State University before forming the nonprofit Northern Utah Sexual Assault Nurse Examiners, New SANE, in 2005. She is the founding CEO and clinical director of New SANE and continues to see sexual assault patients at the Northern Utah Forensic Examination Center in Ogden, Utah. Welcome, Jeanlee.
Thank you.
So, who gets to ask first questions? Go ahead. Go ahead.
Jeanlee, it's a pleasure to have you here.
Thank you.
What an impressive resume. Just the difference you've made in the community where I practice is incredible. And I can see that that's spread out throughout the state. So it's wonderful. I'm a frontline practitioner, family practice. I see all ages. But probably my training in sexual abuse, recognition, treatment, counseling, and health has been very minimal. How much do healthcare providers, in your experience, how much do the providers know about sexual assault and domestic violence in our community?
I think very little. I imagine, and what I've been told is that during their education and residencies, that they rarely have an opportunity to interact with these patients. And so I think it's important for those of us that see victims of violence, sexual violence, that we are able to provide that continuing education for providers within our community. You do a wonderful job at your clinic. It serves a huge population need, and I'm sure we've seen patients. We probably share patients.
That's true.
And but I think that the opportunity for interns and residents and even medical school, there's very little focus on this area. Dr. Campbell has had me come and speak to the family practice residents about child abuse and neglect. And, I've been to the nursing schools and nurse practitioner schools, etc. But I think we need to do more.
Okay, wonderful.
So one of the things that I wonder about, maybe you could address. So when a patient has been through your clinic and has had the initial evaluation, and then they come back into our office, what sort of things should we be looking to provide in that setting?
That's an excellent question. What we do when we see a patient, we are now going out 6 days post-assault. The forensic science has grown in such a way and gotten so much better that, it used to be 72 hours after a sexual assault that you had to see a patient in order to collect evidence and provide care. Well, we went to 5 days and now we've gone to 6 days out. And that's because of the advances in forensic science. That gives us an opportunity to meet with these people, of course, assess them for injury, collection of evidence, but also provide sexually transmitted infection prophylaxis. So we provide medications for chlamydia, gonorrhea, trichomoniasis, and pregnancy prevention, and then screen them for HIV risk. So what needs to be done when they come to see you, and we encourage this in our discharge planning, is we would like them to see their primary care provider within 2 weeks of seeing us. And at that time, they should be screened for STI. Of course, we have given them the prophylaxis, but as we all know, that doesn't always work. So the screening for those infections is very important. Also, hepatitis. Some of these patients have not been immunized. Some have been immunized just with one vaccine. And so our goal is to make sure that their health is optimal after this event, this assault. And so that's what we would hope that you would provide. Also, if there is any injury that we see, these patients don't necessarily need to have a genital examination unless they have sustained injury, and injury that we would hope that you might take a look and make sure they were healing appropriately. We all know that that area of the body heals very quickly and usually without any complication. And the injuries are usually minor, but sometimes we see something that's concerning. But that would be the only time that we would appreciate a genital exam post-assault.
Okay. Well, you mentioned one thing. So in your initial evaluation, you're providing medications for prevention of infection if possible, but you also said pregnancy prevention.
Yes, and we really should use the term interception. And we have patients that decline that. Every part of the sexual assault examination is guided by the patient. Every single thing we do, if they don't want that part of the exam, they don't get it. They don't have to have it. We explain to them about the STI prophylaxis. We talk to them about the pregnancy interception. This is a hormonal administration, Plan B. And, there are several different brands, which makes the environment for conception to be not optimal. But some women prefer not to have that. That's their choice. And so that is discussed during the consent signing, as well as before medications are given.
So with the change in the legal environment nationally in regards to abortions, how has this affected this treatment, if at all?
Well, at this point, it has not. We've been fearful that it may change our ability to provide this service. However, considering that this is not the abortion pill, and I'd say that in quotation marks, it is a deterrent to pregnancy occurring at all. We're hoping that we'll be allowed to continue to provide that.
Okay.
Jeanlee, you opened a whole lot of questions in my mind, which I appreciate. And maybe I'll just go in one direction right now. in my naivete, I would imagine a majority of the sexual assault victims enter medical care through an emergency room at a hospital. How, if that's the case, how do they interface with the sexual assault nurses? Or if I were to see them in my own urgent care downtown or in my regular practice, how would I interface and how would I contact them? How would I start the process with a sexual assault nurse?
Great question. We see a lot of patients who respond to the emergency department for help. In this area, Ogden Regional Medical Center, McKay Hospital Emergency Department, we see patients from Bear River Valley all the way to Lakeview and Bountiful. If a patient responds to the emergency department, we have an answering service, and the emergency department physician, social worker, they call our answering service. We have a nurse on call 24 hours a day, and they respond. Usually a conversation occurs, is the patient medically stable? These examinations are lengthy. It can take 3 to 4 hours, which ties up an emergency department room, a doc, a nurse, and so one of the beauties of having this clinic right in Ogden City is that if the patient is stable medically and would like to come to our clinic, then we meet them there. We also can go to any emergency department in the area. So all it takes is a phone call. Your clinic, if you're in your clinics and you have someone come to you for help, then you call us and we make arrangements to see the patient. If the patient doesn't have transportation, we make arrangements for that. We also have advocacy involved in every exam that we do. And so the support system begins then, as soon as we get the phone call. So, reaching out to us for people outside of the Weaver, Morgan, Davis, and Box Elder area, there is a sexual assault tip line for our state. And you call that number and you get the team that's within your area of the state of Utah. We have responded to long-term care facilities. We don't go to people's houses. We do go to all the correctional facilities for patients who have been assaulted prior to incarceration or while incarcerated. So it really just takes a phone call.
Sure. So I remember years ago, there was a dust up about the sexual assault clinic location. It was in South Ogden, I believe.
Mm-hmm.
And I just remember vaguely that I guess Progress said it had to move. So where are you now and what is the clinic
Okay.
like?
All right. This is a great question. Yes, we were in South Ogden in 2005 when we started New SANE. We were all nurses in the hospitals, emergency departments mostly. And at that point in time, there was no team at this part of the Wasatch Front. There was a sexual assault team in Provo, one in Salt Lake, of course, even one in Logan, but nothing for the members of this area community. So when we started New SANE, we knew we didn't want to be in the emergency department. It's busy, it's chaotic, it's noisy. This hospital, McKay emergency department at that time in 2005 was the busiest emergency department in the state of Utah. And so we knew we wanted to get those patients out where it was quiet and confidential, and they had one-on-one care, and there weren't other people around to worry about confidentiality. Someone comes to the emergency department because of a sexual assault, and their neighbor sitting next to them in the waiting room, or their pastor, and then the police come. And so it's, ERs are really, I think, a difficult place to maintain that kind of privacy, even before they get into the emergency department. So that's why the clinic was established. So during that time, South Ogden City, their police department, they were moving into their new municipal building. So they gave us the law enforcement wing and let us be there, and we laid carpet and painted and hung wallboard and made a clinic. The law enforcement officers helped us, and our family helped us, and we put a clinic together. And so that's where we started seeing patients. Then we were there and happy for quite a while. But then, as you say, Progress moves forward, and they decided to sell that property and demolish the building. which they did, and we were scrabbling for a home. So we are now at the Weber Morgan Health Department, which is a beautiful building, and they asked us to come and have our clinic there. So we have a wing of the health department on the main floor. We enter through a locked door, which is the employee entrance, is locked. You have to have a badge to get in. And we have a beautiful waiting room, an exam room, storage. We're self-supporting, i.e. we buy all of our own medical equipment and supplies and office supplies. We run this clinic. And so we're right in Ogden. So it's right in the health department at, what's the address?
23rd Madam.
Yes, 477 23rd Street. Yes. And so, as I said, we see patients all over the valley, but we also have a clinic. And we're the only ones in the state of Utah. And so many of the teams are really envious of what we have here. And not me, I'm not saying us, I'm saying our community has this facility specifically for sexual assault, domestic violence victims.
Wonderful.
Yeah.
So I imagine that there are several different pathways patients choose to take. One of those can be a legal pathway. How is the exam or the evaluation different if they are going to pursue legal course?
Well, I think any patient that we see has the right to cooperate with law enforcement or not. And the goal has been for sexual assault nurse examiners as well as advocacy is not to lose the evidence in case they change their minds. So the exam is no different. If the patient says, I don't want to talk to the police, I don't want to talk to the police, they don't have to talk to the police. They have to decide if they want a forensic exam. Do you want evidence collected? And I always thought to myself, why would you go through that if you weren't going to talk to the police? But the goal has been once some of that initial, that acute trauma subsides a bit, and they gather their support system, they have advocacy within, YCC is who helps us in Weber County. They've gotten to a point where, okay, now I'm mad, and now this isn't right, and now I don't want him or whomever to do this to someone else. So they change. They say, okay, I want to talk to the police now. Well, if we hadn't had the exam, we have no evidence. But if we do the examination, we as healthcare providers are responsible to report to law enforcement. And that was one of Dr. Rifleman's question was, what are our responsibilities as providers with regard to the law? Now, as healthcare providers, if we know that an assault has taken place by another individual, we are mandated by law to report that. That doesn't mean the patient has to speak to law enforcement, but we have to report it. And we tell law enforcement, if we're the ones reporting, which we speak to law enforcement on every case, you guys don't have to do it. We tell them they're not wanting to speak to law enforcement at this time. So we get a case number, we move through the process, gather the evidence, same exam as anybody else, whether they're speaking to law enforcement or not, same exam. And then the jurisdiction in which the crime occurred, that law enforcement department takes custody of the evidence and holds it.
Oh, okay.
Yeah.
For how long? I mean,
well, they reach out to the victim and talk to them. The detective will call them in 2 or 3 days. This is Detective so-and-so from North Ogden PD. Do you feel like you could talk to me a minute about what happened? And so they go over that. They go through that scenario. And if they adamantly refuse, or they will then at some point destroy the evidence.
Okay.
But if they say, well, I don't know, I'm not ready yet, then they hold the evidence. And then they call back and say, how are you feeling and how are things going? And have you spoken to your advocate? And do you have a support system? The law enforcement officers, I have to say, have really stepped up. and learned about, trauma-informed interviewing and care of these victims. And so not only in sexual assault, but with domestic violence and strangulation. And we've all learned so much in the last even 10 years about how to better provide service.
So you mentioned a word.
What's the word?
The word was strangulation.
Oh, okay.
And we have been focusing on this, on sexual assault up to now, but that is only a portion of what you deal with.
Yes.
And if I remember right, you told me in the past that strangulation was increasing in frequency.
Strangulation has increased, yes, across the nation. During the time of COVID, domestic violence in itself increased by 40%. We were all secluded in our homes. Tensions were very high, stressors were very huge. And so what happens is we had an increase in domestic violence. With that goes strangulation. There's also an increase in strangulation among our young population during sexual activity. And they're seeing this online where strangulation is occurring during sex. And so they think this is what you do when you have sex, is you strangle your partner. So there's been a huge increase and a huge focus internationally on strangulation, the acute and chronic effects of strangulation. And so we know that we see strangulation in domestic violence. We also see it in sexual assault. We also see it in consensual sex. So it takes a lot of education. What do you do for prevention? How do you keep that from happening? It is the ultimate power and control of an individual. You hold their lives in your hands. So yeah, it's a huge issue.
It's one I don't like hearing about, as is many of these.
Yeah.
Sure. Jeanlee, could I just back up on just a couple
Yeah.
questions that we talked about, then we'll move forward again.
Mhm.
You mentioned, and we talked about some of the legal reporting requirements. We're in the state of Utah. My question would be, what you told us, is that true for all 50 states? Because we have listeners across the nation.
I'll tell you, they're all different.
They're all different.
Every state's different. And so no matter where you are in the nation, you need to find out what your state, their statutes are. In our state, any vulnerable adult, so a mentally ill individual, somebody who is intellectually challenged, an elderly person, any vulnerable adult who is victimized by anyone else, our entire population in Utah is a mandated reporter. Anything that has to do with the child, that's anyone under the age of 18. Any neglect, any abuse, any sexual perpetration, anything. The general public, as citizens of the state of Utah, are mandated reporters. So when we look at healthcare providers, it's a little different. And that is, if you have an adult come into your practice and she's or he is competent, and they say to you that they're fearful to go home, say, or the person they live with has threatened them with a gun, then you are mandated to report that. So threat of harm, okay? If somebody comes into your clinic with vaginal bleeding, and so you do a genital pelvic examination and you see the source of that bleeding, which appears to be trauma, then you, of course, you're going to say, can you tell me what happened here? And if they report to you that someone sexually violated them and injured them, you are a mandated reporter. So harm, has someone been harmed? Has someone been threatened to be harmed? That's when you have to report as healthcare providers.
Great. And then again, the adult patient, they have a decision whether or not they want to interface with the law, right? But I would call in the jurisdiction we're report
Mhm.
occurred. But would the police officer respond to the clinic at that point?
No, what you would have is you would, in fact, depending upon where you are in the nation and what kind of resources you have with regard to sexual assault nurse examiners, you wouldn't have to call law enforcement. You could call us.
That would be adequate.
Yes,
the
and
reporting
then
requirement.
we're gonna call them because you have made sure that the report is going to happen. Because we report to law enforcement. So depending upon where you are in the nation, what the laws are that are, I believe these are federal laws in many instances around the fact that if you know someone has a gun and that your patient has been threatened by her husband who says, I'm going to kill you, and you don't call the police, that's on you. So, yeah, I think it's important everybody know their state laws, and also the fact that in
You want to
this,
say that again?
in
I think it's important.
important that everybody know the laws within their own state, and also they need to also know if there is a team sexual assault nurse examiner resource for them in their communities.
Yeah.
And if not, where is one? Where's the closest one?
It seems like a no-brainer to practice in any community. You should know that.
Yeah, but
Well, just another quick question. You mentioned that perhaps maybe a victim would be seen by the nurse examiners. The process started, evidence collected, but they may need a follow-up, and they may come back to the primary care or come to the primary care.
Yeah.
Is there any type of formal communication between your clinic and my clinic?
there is not verbal communication. We give every patient that we see a discharge document, which lists the medications they've received, when we would like them to see their primary care provider, and who their resources are, what advocacy program, et cetera. And we encourage them to take that with them.
Perfect.
Make an appointment within 2 weeks and take this document with you so that you all know exactly what they've received and what we are hoping to accomplish with their visit.
So one thing that's come up, especially with residents, that is not necessarily as traumatic as some of this, is when we have a patient that there may have been a question of, did the babysitter do something?
Mhm.
And the physician, especially in training, examines them and thinks, I have no idea,
Mhm.
because they aren't experienced enough to know even normal potentially, because we don't examine a lot of genitals in little kids.
Mhm.
That's something also we can reach out to you and ask for support.
Well, we only see patients 14 and above.
Okay.
However, as you know, child abuse and neglect was my primary practice for many years. And we've talked about this in the fact that you don't look at genitals unless there's a complaint. You know, once the newborn has their initial examination, who's looking at potty parts unless somebody's complaining about something? So you're exactly right. Most primary care providers and general medicine people don't even know all the parts that girls have, which is, there's a lot of them. So I've had referrals, from when I was at the Children's Justice Center, referrals from physicians, pediatricians, family practice docs, for all kinds of things. And, a red bottom does not constitute sexual abuse, but how do you know? So that then needs to be referred to their, either in the nation, their children's hospital, closest children's hospital, or hopefully in other states of the nation, they're called children's advocacy centers. In Utah, they're children's justice centers. And we're lucky in our community that we have one right down the street, and with a child abuse expert, nurse practitioner, and registered nurse who are employed by Primary Children's, who would welcome a referral from this clinic or your clinic or any clinic if you have questions or concerns.
Okay, good to know.
Yeah.
Beautiful. Well, going back to what happens between myself and my patients in the
Uh-huh.
room, are there red flags? A patient might want to tell me something that happened, but they might be reluctant initially. Is there something I can help to
Yes,
get that history?
absolutely. That's an excellent question. And I think one of the things that we've got to do as healthcare providers is recognize this goes on every day, not so much sexual assault, but violence in the home, even or within relationships. And we have to think of that in part of our differential. If you have a patient who comes to you, and I have one in mind when I was not just but a registered nurse in the emergency department, and I worked triage. And I had the same young woman come in 4 or 5 times complaining of abdominal pain. She wasn't a drug seeker. She didn't want medicine. What she wanted is someone to say, "Is anyone hurting you?" And none of us did. It never entered our minds that she did have abdominal pain, but it was pain that she was suffering from the psychological trauma of this relationship. So if you have patients who have eating disorders, if you have patients who have chronic complaints that you can't seem to find, a physiologic reason for, if you have patients that cannot control their blood pressure, despite the interventions that you have given them, who overeat, who are substance abusers. These things are a response to some kind of trauma in their lives. I mean, we've all heard about ACEs and how adverse childhood events can lead to physical problems, medical problems as we get older. The same with if you are in an unhealthy relationship. And I think sometimes we don't ask the question. And it's a very simple question. How are things at home? How are things with you and your partner? That's all you have to ask. And if they say, fine, then you say, well, I'm a little concerned. And I have, many people in my practice that sometimes are in unhealthy relationships and feel fearful at times. That's the trauma-informed way to speak to someone, not is your husband beating the hell out of you? Or is your girlfriend strangling you? You have to just kind of go in the back door. They can't be threatened. They have to be able to trust you. And if they disclose to you, well, yeah, my husband, he doesn't like it when I leave the house. We had a mother and daughter patient in another community that had been sequestered in their home for almost 2 years. The husband, father would not let them out. He was physically assaulting his wife and sexually assaulting his daughter, who was in her 30s. They'd been there for 2 years. And until they thought the wife was having a stroke because she became aphasic and had hemiplegia, did they dare call 911? And that's how they found these 2 women. So at that point in time, they saw a healthcare provider, and how wonderful that they did.
Sure.
So does that answer the question?
Yeah, definitely. I mean,
Okay.
definitely awareness.
I tend to talk too much.
I
so.
bet Dr. Audrey Jericho, I bet.
Yes.
And
Mhm.
and I really love hearing her talk about this topic also. And
Mhm.
the language she uses, I've tried to incorporate in my practice also, which is a trauma-informed care you're talking about. So I appreciate that.
Yeah, I think for many of us, number one, we have to accept the fact that it's happening. Number two, we have to put it in our differential. The Utah Domestic Violence Coalition, which I'm part of the medical group, we recommend for any healthcare provider who sees anyone 18 and above to ask that question as part of your regular physical assessment, their yearly exam. Just ask the question. Are you safe? Do you feel safe? Is anyone hurting you? There's nothing wrong with those questions. Those are health questions. Those are health history questions, and we should be asking them. But I think you have to accept it's happening.
Yeah, those questions are now part of the Medicare annual wellness visit. Are you
That's
safe?
right. You've asked me that
Yeah,
question.
yeah. And fortunately, you were safe.
I was safe.
Which was
Yes.
good. So you kind of alluded to this. I would like, in my innocence, to think that this has happened in your practice maybe once or twice in your whole career, but I suspect it's more frequent. what kind of frequency are we really talking about? How busy are you guys?
Well, right here in our little area, 4-county spread, we see almost 200 patients a year, which isn't a lot. You look at Salt Lake County, they are now covering Utah County, Wasatch, and one more.
Summit, probably.
Summit, yes. They see like 1,400 cases a year of sexual violence. Now, you've all heard, I would imagine that we, as residents of Utah, know that our percentage of sexual assault is higher than the national average. That's quite embarrassing, wouldn't you say? So you look at, we look at 55 victims per 100,000. The national average is 46. This research is not old. It's within the last couple of years. And we know that the mentally ill are especially at risk. And young women, 94% of our patients are women, 6% are men. So it is a kind of a female thing, even though we're not supposed to talk like that
Sure.
in this day and age, but it is. And so it is happening. We also know that the problem isn't, you hear about false reporting. Oh, she made that up. That's one of the myths, rape myths. And the problem is reporting. We figure nationally about 11.8% of patients who are sexually assaulted even tell anyone. So the problem is people are being assaulted. We don't even know how many, and they're not telling anyone. And I think as women, we say to ourselves, if that happened to me, would I even tell? So it takes huge amount of courage to tell someone and to go for help.
A patient in my practice now has been sexually assaulted in the past. I continue to see her longitudinally over time. Are there things that I need to do with her care? For example, how would I know that she's broken out of that situation or that she's still in that situation?
Well, good question. I think that number one, you look at her health in general. You look at her psychological health, emotional health, physical health. Does she seem to be doing well? The other thing is it's not taboo to ask her how she's doing. And since you have such a long history with her, she trusts you. And I think that trust is huge as healthcare providers. We have to establish that. And I think if you say to her something like, there was an unfortunate incident that occurred, several years ago, has that happened again? That's non-threatening, trauma-informed. You believed her when it happened. You were wondering if she's safe. Safety's the, big thing. So
Sure.
That's how I'd handle it.
You mentioned the ACEs. I mean, for a patient like that, I could see down the road mental health problems. There.
Yes, absolutely.
Physical problems.
Yes.
Could be tied to that.
Yes. I mean, we look at ACEs and we look at, they go about their life, and some of the stories that I've heard, and that I've got stuff in my brain I wish weren't there, but you hear these stories and you think, how did these people survive this trauma as children? And we know that children who are sexually abused during their adolescent years or often become promiscuous, have very unhealthy behaviors, have risky behaviors, and they act out sexually as a response to something that happened to them as they were when they were a child. We know that people who have been sexually assaulted as say teens may also demonstrate those risky behaviors, and it's all a response. It's a coping mechanism of their trauma and what they carry with them. So we have to be patient and understanding.
You don't want to be all doom and gloom. So
I know.
are there success stories of maybe people you've seen that have come through your clinic?
Oh, yes. We've had some excellent success, and I have to tell you, I know a nurse, and she's not from here. She's from the South, and she grew up in a very volatile home, was assaulted as barely a teenager, very young, which resulted in a pregnancy, which she kept, and continued on with her life, graduated from college, has a successful career, is a mother and now a grandmother at a very young age, has a wonderful husband, and is doing very well.
Great.
And she is a source of real inspiration for me. And but yes, we have had people that we have seen say, we just had the Step Foot to Light, which is a YCC annual, Your Community Connection has this annual little get together in Ogden, and it's about domestic violence really, but they do this great little thing where the police departments and we have a table and we give out swag, and the police come and the advocates come and everybody comes, and then they make posters and walk down 25th Street and around just to increase awareness about domestic violence. It's great. And anyway, but there are many survivors that attend those and conferences. We hear wonderful stories at the Utah Coalition Against Sexual Assault, Domestic Violence, and Sexual Violence conferences every year. So,
And does reaching out to others with similar challenges, similar traumatic experiences, has that support been useful for patients?
oh, I think so. I think that when we establish the relationship with the shelter, the advocacy organization, they have an opportunity to sit down in a group and have group therapy or group meetings where they feel so isolated and alone. No one's going to believe me is number one. Everybody's going to blame me. They have a huge amount of guilt. If I'd only done this, if I hadn't walked to my car in the dark, if I hadn't met this guy on the church website, if I, hadn't agreed to let him come over to watch a movie, there's huge amount of guilt and shame, of course, revolving around sexual violence. But having the opportunity to speak to others who have also been through this ordeal and are surviving and are moving on, I don't think it ever goes away. It's just like most grief. It is a grief. We learn to live with it, and we learn coping skills, and we do life. That's the goal.
Well, I have one last question, and that's really for you personally.
Mm-hmm.
I've always admired your willingness to step into places of darkness to help others.
Mm-hmm.
How is it that you have not been overwhelmed by the darkness?
That's a good question. It's probably something totally unhealthy. I sometimes have to go. I remember I was at some conference, and one of the therapists there was speaking, and they told us that we all needed a happy place. And so I have a happy place in my mind. And there are times I have to go there because I become overwhelmed with the darkness that I have seen in my career. The most devastating for me has been child abuse, and neglect. And there were days I came home that I thought, I can't do this anymore. But then I think to myself, who is going to do it? Who is going to see that child? Who is going to look at that 10-year-old and say, I see you, you are important to me. So then I would just muster it up and go back the next day. But I go to my happy place, which is a place I went with my husband in Mexico, and the sheer curtains were blowing and I could hear the ocean crashing. And I go there mentally sometimes in order to, it's when you lay your head down on your pillow that some of this stuff comes rushing back to your head. That's all I know. I don't know. Maybe it was my mother. I don't know.
Well, we are very grateful for your comments today and for your long and truly noble service.
Amen. Thank you very much for coming with us today and sharing a lot of knowledge. And we hope you continue to do that in our community. You're a valuable resource. One of those 1,000 points of light, I'm sure that one of our past presidents talked about.
Yeah.
So,
Well, thank you. I appreciate the opportunity just to share hopefully some information. And please reach out, anyone who needs help.
Thank you.
thank you.